Hi, I'm Tari Turner, Director of the National COVID-19 Clinical Evidence Taskforce and an Associate Professor at Cochrane, Australia in the School of Public Health at Monash University. Welcome to TaskforceTV. I'm recording this today on the land of the Boonwurrung people, and I pay my respects to their elders, past, present and emerging, and acknowledge that this is unceded land. In this episode, we're taking a look at the importance of primary care in COVID and the impact of post-COVID-19. And I'm delighted to be joined by the co-chairs of the Taskforce Primary and Chronic Care Panel, Mark Morgan and Nicole Allard. Dr. Mark Morgan is a professor at Queensland's Bond University in the Faculty of Health, Science and Medicine, where he's also Associate Dean for External Engagement. Mark is the chair of the RACGP Expert Committee for Quality Care, as well as the college's nominee on the Guidelines Leadership Group for us here at Taskforce. Dr. Nicole Allard is a post-doctoral researcher and medical epidemiologist at the Victorian Infectious Diseases Reference Laboratory and a general practitioner and public health lead at cohealth. She's also an honorary lecturer in the Department of General Practice and Infectious Diseases at the University of Melbourne. Thanks both of you for joining me today. We're now at a point with the Taskforce guidelines that there are something like 175 recommendations, and if you chose to print that PDF off, there'd be 700 pages. So I'm wondering if you might help out our primary care clinician colleagues and tell me, what do you think the key messages are? Nicole, what are the key takeaways from the guidelines for people working in primary care?
There's an importance in primary care to understand your patients. You know them best. You often know their context. To identify people who might qualify for therapies to reduce their risk of hospitalisation, and also just the coordination of care, which is still required for people with COVID at home, even though our periods in isolation have reduced quite a lot.
The flowcharts are perhaps the most succinct place to start with looking at the information that the task force has put together.
I'm aware that you guys have had quite different experiences of COVID. Nicole, probably your experience started a little bit earlier in terms of providing care to people with COVID. Mark, it's become more of an issue in Queensland a little bit later in the picture. Can you tell us a little bit, Nicole, about your experience of caring for people with COVID, and perhaps Mark, then I'll come to you about your reflections on any differences.
So I think in my preparation for this, Tari, I had a bit of a look through our 6 lockdowns, because somewhere between 2020 and 2021, it all feels a little bit like the same. But certainly early in 2020, we weren't seeing a lot of COVID in general practice. The case numbers were very few. In our what we call our second lockdown, the major lockdown that was 111 days, Victoria experienced the largest number of COVID cases in that time period. And this was a period when people were unvaccinated, and the hospitalisation rate was somewhere between 15 to 10% of cases. And while the numbers now seem small, it was very significant in terms of trying to work out how primary care should fit into that space. If we go into 2021, we started to see the impacts of vaccination, but even in our last major lockdown, a lot of the people who had COVID were only just eligible for vaccination at the time when that Delta wave swept Melbourne. So general practitioners in Melbourne, especially in Melbourne's northwest, which has had 60% of the cases of COVID, and Melbourne overall had, a large number of the nation's COVID cases up until the Omicron wave. General practitioners have actually had probably more experience in northwest Melbourne than anywhere else in Australia with managing COVID.
And it's been a slightly different journey through COVID for our Queensland colleagues. Mark, what's it been like for you guys?
It's more been a story of protection, prevention and disruption. And I think perhaps the early impact of COVID was actually the loss of business as usual in general practice and the ability to do the very important work for prevention, primary prevention and secondary prevention for our patients. The experience of COVID itself has come much later and more like a flu-like illness in the vaccinated or largely vaccinated population, but still really important to know which patients are the ones that are most likely to need extra help.
And that's the theme I want to pick up on now too, Mark. We're now in a position where we have some treatments available for patients, and there's been a lot of conversations around these oral antivirals and other options that are on the table. Are there things GPs should be kind of having front of mind as they're thinking about these patients, whether they might be suitable and which types of drugs to be considering?
Front of mind is that there's a time frame from start of symptoms to the use of medicines such as antiviral medicines. We need to introduce these within 5 days, and those 5 days could go very quickly if a person is a little bit slow to acknowledge that they have COVID symptoms, and then there's a weekend. You could imagine pushing the limits of those 5 days and missing the opportunity to intervene with antiviral medications. So I think proactive, as we see people who have comorbidities, are in those frailer age groups, we should be letting people know, if you get COVID symptoms, do a test straight away, organize a telephone or video consult at the earliest opportunity, because you might be eligible for one of these treatments. And I think being proactive, using opportunities like the flu injections that we're doing at the moment as an opportunity to reach out to people and pre-warn them about the need for treatment should they get COVID symptoms.
Nicole, any other thoughts about what GPs should be considering as they're approaching those kinds of questions around those oral antivirals or other treatments for mild COVID?
Yeah, I think that's really important. It's that preparation conversation is actually quite important. What we're seeing now with rapid antigen tests is that a number of people, probably somewhere between 10 to 20%, aren't registering their rapid antigen test. So they're not going to be picked up by any symptom. So trying to do as much health promotion in your vulnerable community members as possible is really important. Getting people with complex immunosuppression to maybe have a conversation with their specialist and just to make it clear what pathways they have to access that early care is really important. I think there's a lot of confusion around rapid antigen tests. People often wait a couple of days before they become positive, and just getting out that message that if you're vulnerable and you want an early diagnosis, if you have symptoms and you have a rapid antigen test that's negative, go and get yourself a PCR, get yourself diagnosed, because that's going to give us a few more days in that early treatment cycle.
I want to pivot the conversation a little bit from those first 5 days to the long COVID conversation. So this is obviously, with case numbers rising in Australia, this is becoming much more a part of the conversation. Nicole, what are your GP colleagues asking you about long COVID?
We're in a difficult situation in general practice, and consumers with long COVID are in a difficult situation where there isn't a lot of evidence to inform what we do next. But I think what's really critical, as always, with any sort of chronic disease care, is the general practitioner liaises and has conversations with their patients and tries to link them into allied health or psychological support. I think also, understanding, particularly for my patient group, where people often have English as a second language and they've had COVID at some point in the last couple of months and they really don't know what to do or how to present. So encouraging people to present and work out what pathways of referral are available.
I think there's a real need to keep an open mind and a respectful conversation about the symptoms that people are presenting. Not all symptoms that are distressing will be related to COVID. And so that's why GPs need to keep an open mind about alternative diagnoses. And by the same token, because long COVID is something we don't have a big evidence base for, there's a temptation, I suppose, to not be able to offer specific treatments, whereas I actually think that GPs do have a set of generalizable treatments and suggestions for patients that are really valuable to help them live through the symptoms of long COVID, whatever those symptoms will be. So I'd encourage my colleagues to think about how they can use knowledge that's been developed over the years for managing similar presentations and use that same information to help manage the people with potential long COVID.
Nicole, any other thoughts about the long COVID experience?
Yeah, I mean, I think providing an open mind, as Mark said, and providing a place for people to talk about their symptoms, obviously looking at their other comorbidities, encouraging people that most symptoms will resolve, but that you're going to be there with them. And you're going to keep yourself up to date with the evidence in the area as it emerges. And I think we will see it emerge over time. And we just need to use some general principles of care, chronic disease, pain, respiratory care, apply those, be honest with our patients about what evidence does and doesn't exist, and just say, but that you'll be there with them to assist them on their journey of recovery.
So you've both flagged that long COVID in particular is an area where there are many unknowns, and hopefully we'll get clarity over the next little while. Mark, I'm interested, are there other important unknowns in terms of treating people with COVID-19 in the community setting?
Yes, I think the prevention, what you could do to prevent long COVID is a really interesting question, and there's very little known about that. But if there were ways to head off a future problem, that would be far preferable to trying to manage the difficult problem when it's there. I think we need to keep reminding people that vaccination is still a really important, vital component of the management of COVID-19. And although there could be distractions of medicines that are available and therapies that are available, but I think vaccination is still something that we should be strongly promoting. And then the other side would be general healthy primary prevention. We continue to work with people that are wanting to give up smoking. We should be continuing to work to optimize the management of other long-term medical conditions.
Nicole, what are the biggest unknowns for you? What are the gaps in knowledge that you'd really like to see filled?
I think as an epidemiologist, there's a few epidemiology gaps I'd like to see filled. Obviously, we've had a massive wave of infection in the last nearly 6 months. And it's obviously important to know how that's going to impact on the prevalence of long COVID, for example, or the incidence as well. I think also, understanding the complex immune factors that are causing long COVID will hopefully start to indicate which direction we'll go with treatments. And I think also really appreciating who we've missed. So vulnerable communities who've had COVID, who haven't had access to care, people who aren't Medicare eligible, a lot of people in our society who've had it quietly at home and who actually need to have sort of almost proactive outreach to have support. So lots of unknowns, but then there's also a huge amount of research going on. So I would like to see some of that research more focused in the primary care space where most people are actually going to present.
Are there particular questions that you'd like to see addressed in that primary care space? If somebody was giving you the decision-making ability for new research funding, are there particular questions that are burning for you?
I mean, there's obviously lots of questions, whether what should our approach be specifically to persistent cough and shortness of breath, to understand what interventions would actually be useful for recovery, and to have those done in representative populations in primary care. So those are the sort of questions that are going through the back of my mind. But there's a lot we still have to learn.
I'm very much hoping that some of the research that we engage in for COVID will actually accelerate the research into the management of tiredness and the management of other medically difficult to explain symptoms. I think there are big gaps in research because it's been difficult research to do and difficult research to seek funding. And the hope is that one of the silver linings that come out of COVID is an increased attention to researching these areas.
So Mark, if I could give you a magic wand, if you could make one wish, maybe it's a genie in a bottle, what one thing would you change to improve the care for the primary care of people with COVID-19?
I think that one of the biggest risk factors for all medical conditions, and that would include COVID-19, is poverty and poor access. And so my wish would be that we could provide the same top level care, appointments of the right duration, and access to care across the populations, and that would include places that and groups of people that traditionally have lower access to care. So it's actually a more almost an economic wish to be able to fund appropriate primary care for all of those harder to reach groups and communities, because they are at higher risk.
If I get a chance to echo your wish, I'll certainly take that one up. Nicole, if the wand was passed to you, what would be your one change?
I think I'd wave it in the direction Mark's waved it first, but I think I'd also like to see a really good consumer campaign targeting different groups to give people information so they're not sitting at home, so they know where to approach. And maybe while I did that, I just asked for a bit of extra workforce, because the general practice workforce is under a lot of pressure at the moment.
Am I allowed a second wish?
Go for it.
Because I would like to wish that we built the infrastructure to collect data from primary care and to analyse it effectively. And at the moment, there are fragmented and small ways of collecting information, and a lot of information that's sitting there in individual GP practices is not able to be used for effective research into what works, what doesn't work, who's at risk, who's not at risk. And I think there's a lot that could be done without a vast spend of money to improve the situation and to try and get information out of electronic records sitting in GP practices in a way that doesn't infringe people's privacy, but does allow optimum secondary use of that information. You're
right. I mean, I think you've flagged a couple of times, there's opportunities for us to learn from this COVID experience, right? I mean, whether it's in that building that data infrastructure or research that's conducted around other elements of COVID that might have value beyond it. Just thinking, if there was one thing to say to your GP colleagues out there managing people with COVID-19 as we wrap up, one message for your colleagues, Nicole?
Look, it's become part of everyday care. So we've got to work out a way to integrate care into normal practice, to best use the respiratory clinics as they're funded currently to minimise the risk to other patients in our practice, and to promote, prevention and then also early treatments.
It seems to me that the GPs and primary care practitioners are pretty good at managing all that complexity, and this is just throwing another kind of level of complexity into that already pretty complex piece. Mark?
I would recommend that my GP colleagues bookmark a source of trusted information and refer to it regularly to get the latest information about where the science is taking us and what has evidence behind it and what does not have evidence behind it in terms of treatments for COVID and for long COVID. So with no bias at all, I recommend the Taskforce and our flowcharts as perhaps the place to have bookmarked and try and cut through some of the vast kind of epidemic of information that comes flying at GPs on a daily basis.
Thank you both for sharing your time with us and your expertise. I really appreciate it. I hope everyone's enjoyed today's show. If you've got questions you'd like to ask experts like Mark or Nicole or other members of the Taskforce team, please feel free to send them through. You can post them on our website or email us. And do share this and the other Taskforce TV episodes with your colleagues, and look out for the next episode of Taskforce TV. Thanks, everybody.